the art, the craft, and the science.
Ravi sir?
The first one we started was at DOS. So I'll hand over the mic to Dr. Shkeen Singh first because I'll be speaking first.
So I welcome you all for this very interesting session. So as we have our chief instructor ready with his talk, versatile Dr. Taliwal, master in MICS. So I would request Dr. Taliwal to please have his talk. That's a manual sick, a surgery for all reasons, a surgery for all seasons, an introduction.
Good afternoon, everybody, respected colleagues, dear residents and fellows. It is a privilege to begin this instruction course on manual SICS, the art, the craft, and the science with this introductory talk titled Manual SICS, a surgery for all reasons, a surgery for all seasons. Every surgeon, at some point in their professional journey, pauses to reflect on a deeper question: is what we practice merely a sequence of technical steps, or is it a responsibility that blends knowledge, judgment, patience, and compassion? Cataract surgery stands beautifully at that intersection. When a patient comes to us with a cataract, it is not just a cloudy lens that they bring to our clinic. They bring with them a life that has gradually begun to fade in clarity. A farmer who can no longer see the boundaries of his field, a grandmother who struggles to recognize the faces of her grandchildren across the room, a craftsman whose livelihood depends upon precision of sight. For them, restoration of vision is not merely a clinical outcome, it is the return of independence, dignity, and confidence. And in this journey of restoring sight, manual SICS, manual small incision cataract surgery, occupies a very special and enduring place. Over the past few decades, cataract surgery has seen extraordinary technological evolution. Phacoemulsification platforms have advanced tremendously. Sophisticated machines and energy-based technologies have refined surgical possibilities. Yet, even in this age, one of the most dependable and versatile techniques in the hands of a thoughtful surgeon. So, why does this technique continue to remain relevant even today? Because it answers many clinical situations with remarkable balance. It performs exceptionally well in dense and mature cataracts where other outcomes with minimal dependence on expensive infrastructure. It adapts beautifully to varied surgical environments from tertiary referral centers to outreach settings serving large populations. But beyond these practical advantages lies something deeper. Manual SICS places the surgeon at the center of the procedure. It demands an understanding of tissue behavior. It requires the surgeon to appreciate the architecture of the scleral tunnel, the dynamics of intraocular fluid movement, and the delicate relationship between capsule, nucleus, and the surrounding structures. A well-constructed scleral tunnel is not merely an entry point into the eye. It is a carefully designed structure that determines wound stability, chamber maintenance, and post-operative comfort. The process of hydro procedures is not simply a mechanical maneuver. It is a dialogue between the lens and capsule, allowing the surgeon to guide the nucleus safely into a position where it can be delivered with control and grace. Even the moment of nucleus delivery carries an elegance that reflects surgical maturity. When performed with understanding, it becomes a smooth and predictable step rather than a moment of anxiety. In many ways, manual SICS represents a training ground for surgical wisdom. It develops tactile sensitivity, it builds spatial awareness, it teaches patience and respect for ocular tissues, and once these qualities become part of the surgeon's instinct, they enrich every other form of cataract surgery that one may perform later in one's career. For countries like ours, where the burden of cataract blindness continues to be significant, techniques that combine safety, efficiency, affordability, and excellent outcomes become immensely valuable. Manual SICS has played a transformative role in restoring sight to millions of individuals, and it continues to empower surgeons to serve communities across diverse settings. This instruction course today is designed not merely to describe the steps of surgery, but to deepen our collective understanding of it. Over the coming presentations, my esteemed faculty friends will guide us through the essential elements that make this surgery successful. We will explore the principles behind creating the ideal incision and tunnel. We will discuss the challenges of nucleus management and the strategies that help overcome them. We will reflect on the delicate responsibility of managing the capsule. We will examine the subtleties of hydro procedures that enable safe nuclear prolapse. We will also look at the evolving refinements and innovations that continue to shape and improve this technique. For the young residents and fellows present here today, this journey is particularly meaningful. Mastery of manual SICS equips you with a level of surgical confidence that extends far beyond a single technique. It prepares you for complex situations, it strengthens your decision making, it ensures that wherever you practice, you carry within you the ability to restore sight safely and effectively. For experienced colleagues as well, revisiting the foundations of a technique often reveals subtle insights that enrich our daily surgical practice. Ultimately, cataract surgery is not defined by the removal of an opaque lens. It is defined as by the restoration of clarity in someone's world. Every successful surgery allows a person to return to their work, family, their books, their prayers, and their dreams. Manual SICS continues to serve that purpose with quiet reliability and profound impact. As we begin this instruction course together, I warmly welcome each one of you to engage with curiosity, openness, and thoughtful discussion. Let us share experiences, learn from one another, and refine understanding that ultimately benefits our patients. Thank you for being here, and I warmly welcome you all to this course.
Thank you, Dr. Aliwal, for enlightening us such a good talk. So as we know, the major blindness is the cataract, and majority of the surgery done cataract surgery, and amongst those cataract is the MSCS is most commonly done. So though has many challenges, different steps, right from the anesthesia, conjunctival incision management, tunnel fashioning, nucleus management, capsular access, aspiration, IOL, toric, multifocals, has many steps to learn, but this is a surgery not for the poor, not by the poor, but it's a quality which we can add into this. So not wasting much of the time, I would request Dr. Trehin to please, change. Yes, Dr. Trehin to please come for with his talk. Sir is going to speak on crafting the perfect incision, the key to success in small incision cataract surgery. sorry. So he's going to speak on management of capsule in manuals SICS.
है ना ठीक है Good afternoon. First of all, I'd like to thank our chief instructor, Dr. Dhaliwal, for giving me chance to speak on topic of my choice, capsular management in manual SICS. This proper capsular management in M6 vital for safety, effective nucleus delivery as well as stable IOL implantation. I am going to cover preoperative factors, crucial capsulotomy methods, approaches to protect the capsule throughout surgery, pre and post, ensuring optimal outcome for patients undergoing M6. This is a brief anatomy of this lens capsule. This is clear elastatic basement membrane. It is vascularized during embryogenesis but later become transparent. It grows with lens throughout the life, permeable to low molecular weight compounds, thinnest at the posterior pole only 3 to 5 micron, thickest at the equator 17 micron, and anterior pole thickness keep on increasing with age from 11 to 15 micron. For capsule procedures, pupillary dilatation is must. It should be 7 or more than 7 is preferably, just to ensure clear surgical field. And some other risk factors we have to keep in mind preoperatively: posterior polar cataract, pseudo exfoliation, traumatic cataract and hypermature cataract. Use protective visco agents like HPMC or OVD to safeguard the capsule during surgery and minimize the capsule. This is CCC, continue curvilinear capsular axis, very simple steps. This is gold standard of capsulotomy techniques, and this will provide us strong controlled capsular rim 5.5 to 6.5 millimeter, facilitating secure nuclear prolapse as well as stable IOL placement. Instruments that can be used for capsular axis: most common 26 gauge needle cystitome, Utrata forceps, microcapsular axis forceps, Haldipurkar forceps, Jepto, Femto, RF. This comes with Artley machine, RF forceps. Even with Simcoe cannula, we can complete the axis, keeping the AC deep. These are the special cases require adapted techniques to ensure capsular safety. You can use trypine blue to improve visibility in mature cataracts. Alternatives like can opener capsulotomy are reserved for challenging cases, but really carry high risks of radial tears and unstable IOL fixation. Two-stage capsular axis, we can start with small and later enlarge for better control. Spiral axis is also some peoples are doing. Envelope capsulotomy, now rarely used, was another alternative. These methods help manage difficult visualization and improve outcomes in challenging capsular conditions. This diagram I want to highlight because most common complication of rhexis is runaway of the rhexis. Just try to see this anatomy. Jonular attachment is like when AC is of normal depth or slightly deep, each and every jonule is relaxed. If AC becomes shallow, jonules come under pressure. And if jonules are pulling and we are giving rhexis, likely to run away. So always keep in mind, we have to keep it deep anterior chamber. But one thing we have to keep in mind also, in high myopes, if we further deepen the AC, likely to be, at least in novices, then jonules are also under pressure. They will also chances of runaway of the most common complication, runaway, and this is a simple technique I get from Dr. Pradeep Mohanta. We have to work on Z axis. Routinely we are doing rhexis on X and Y axis, but if it is going out, running away, we have to use, after deepening the anterior chamber, we have to pull it, and this sudden jerk will rescue us, but we have to keep in mind and titrate each and everything, likely to cause problems also. Hydro procedures, hydro dissection should be gentle and multi-quadrant to confirm nucleus mobility without stressing the capsule, and one has to avoid in posterior polar cataracts. Hydro delineation, this separates nucleus and epinucleus, again reducing the capsular stress. During nuclear prolapse, ensure capsular axis is adequate. Prolapse one pole at a time. Avoid jonular traction. Maintain chamber depth with ISCO to protect the capsule. Use Simcoe cannula for cortical cleanup. If intact, perform gentle polishing. In case of PC rent, immediately inject visco and avoid chamber collapse. I'd like to mention about nano knife. This is a special knife, helps to clean posterior surface of anterior capsular cells. Special situations, PP cataract, no hydrodissection, pseudo exfoliation, larger CCC, CTR should be handy in hypermature, trypan blue and control CCC. Post-op issues like PCO are minimized through cortical cleanup, capsular polishing and square edge IOLs, and these are the conclusions. Proper pre-op assessment, technique selection, intraoperative capsular protection, reduce complications and enhance IOL stability. Recognizing special cases, manage post-op risk like PCO, ensure improved patient vision and long-term surgical success. Thank you.
Thank you, Ravi. That was a wonderful talk. And now I would request Dr. Karamjeet Singh to tell us what's new in manual SICS. Well, whatever he's going to tell us is really very new. Dr. Karamjeet.
Thank you, sir. Thank you very much. Actually, we have to go to some other session. That's why. Thank you very much. So, as we all know that there are so many new innovations, new techniques which are these days applied to various techniques of not only in cataract surgery but other techniques of treating the ocular diseases. So manual small incision cataract surgery, that I think this is as old as the history of the cataract surgery. So it has evolved for years since its inception by the blue menthol technique. So previously we used to do blue menthol technique. Most of our teachers, they prefer to do this blue menthol technique. But over the years, there are so many smart SICS techniques, which not only in India, which are now popularized in the Western world also. So in that, the scleral tunnel in non-phaco cataract surgery is the most evolved technique. So it started with the type of incisions. Previously, we used to do even clear corneal cataract surgery, then the various incision shapes of the incision, the size of the incision, like that. But these days, even we are doing the topographic guided incision, which are mostly we apply on the steep axis. So incision size, it matters in all cataract surgery techniques, right from large incision cataract ECC IOLs, then phacoemulsification, and even SICS. So 2 mm SICS, I used to do most of my surgeries with 2 mm or 3.5 mm incision, according to the hardness of the nucleus. So 2 mm incision technique, it promises a sutureless, easy to perform, and with very low astigmatism, and it is as good as phacoemulsification. And also in the bag nucleus division, viscodissection, these, and also the methods of the nucleus delivery through very small incision. These are the also newer innovations which we can see preferred by various surgeons. So my technique is basically 2 mm manual small incision cataract surgery with in the bag nucleus division, or with dissection with viscoelastic according to the grade of the nucleus. And after that, the nucleus delivery through the 2 mm tunnel, small incision tunnel. So this is a short video of the 2 mm incision. After so this, you can see I mark my 2 mm incisions. So after that, I give 1.5 to 2 mm back cuts. So this technique I am doing for last 3-4 years. So this is how we place our tunnel. Practically the outer incision is approximately 2 mm, and the inner incision is approximately 5.5 to 6 mm according to the size of the nucleus. So rest of the steps are good hydrodissection. Then after that, enlargement of the inner incision and a little bit of the tunnel. So then prolapse of the nucleus into the anterior chamber. So if nucleus is of 2 to 3 grade, I used to divide the nucleus with my visco cannula into 2. And with this specially designed vectus, which is designed by Dr. Sahu, so I expulse the nucleus out. So this is how we can divide the nucleus into the anterior chamber with simple visco cannula, and after that we can with the help of the with the help of the vectors, the nucleus is out. So this is another little bit white cataract, and it is little bit hard. So 2 mm tunnel is the same as I explained in my previous surgery. Practically the outer tunnel, you can say it is 2 mm. Then rest of the steps, like in this we need a little bit bigger capsular axis, little bit bigger capsular axis for the good manipulation of the nucleus into the bag, or even expulsion of the nucleus into the anterior chamber. So in this, the inner incision is approximately 5.5. So with this pre-chopper, I divide the nucleus into 2 in the bag only. So this is, then after that, the one part of the nucleus is expulsed out in the anterior chamber, and with this 2 mm vectors, specially designed vectors, the nucleus is out. So this is another here So after very good nucleus rotation, so nucleus is basically out into the anterior chamber, and with the simple visco cannula, we can divide the nucleus into two. Even Dr. Ravi Trehan, he is used to divide according to the suture lines. So there the little force is required to separate the nucleus at the suture lines. So this is how we divide. Even we can divide 3 or 4 in the bag or in the anterior chamber also. The rest of the surgical steps are same. We can implant intraocular lens, multifocal intraocular lens. Even we can implant 5.5 mm hard lens. For that, the incision should be, the back cut should be little bit longer, 2.2 mm or 2.5 mm. But for foldable lens, 1.5 mm back cuts are sufficient. So this is how we can, although initially in some cases we find that there is, so these are the instrument that we used. These are all instruments are designed by Dr. Sahu, and these are easily available. So we compare our this 2 mm technique with the phacoemulsification. So we find very good results as compared to phacoemulsification. Results are almost as good as phacoemulsification, although in the beginning we may find a little bit corneal edema, but that is cleared within 5 to 7 days. So to conclude my talk, the visual outcome at 6 weeks were comparable between all the techniques of cataract surgery. And so 2 mm incision has all the advantages of phacoemulsification. It is cost effective and very few instruments are required. Indication basically depends upon surgeon's experience, skill and expertise. But I must say that it is not the technique of choice for the beginners. First you should master in the manual small incision cataract surgery. After that you can do 3.5 mm and then 2 mm technique. So it has very few complications in the experienced hand. So thank you very much. Thank you for your patience hearing. Yes, sir. Sir, the outer incision is practically 2 mm with the 1.5 mm back cuts. So, and there is a very good healing with this 2.5 2 mm tunnel. So these days 2 mm keratomy is also available. So and there are special instruments designed by Dr. Sahu, and it is very easy to manipulate the nucleus with those instruments. So, but I always advocate to my residents that first you should be well conversed with the 5.5 or 6 mm incision, then go to 3.5 mm incision. 3.5 is also very good incision, and after that you can try 2 mm incision. It is not directly that you can go to 2 mm incision.
I would like to add one more point here, that is courtesy Dr. Karamjeet. His residents are very proficient in phaco, and a girl comes back and tells him, sir, you तुसी मैनू कुछ पढ़ाया ही नहीं, आपने कुछ सिखाया ही नहीं, because she didn't know SICS and her hospital didn't have a phaco machine. So he started a course on SICS for people who had gone from his college earlier. So now they are taught SICS also.
I think we should all practice SICS, because there are so many cases that we can deal with SICS well as compared to the phacoemulsification. Thank you very much. Thank you. for your patient safety.
Thank you, Karamjit.
So next, I'll like to invite Dr. Shakeen Singh. Sir is going to talk on temporal SICS. So it's going to be in another competition with temporal phaco.
And before Dr. Shakeen Singh starts his talk, I would like to tell him he performs temporal SICS in such a way that anybody who's seeing it says, इस cataract surgery में तो कुछ भी नहीं होता, ये तो 2 minutes में हो जाती है. So he performs SICS temporally with that expertise. Would you like to add something to temporal SICS, Karamjit?
Yes, sir. So actually these days we have to fashion our incision according to the astigmatism. So these days there are so many tools, so we can accurately place our incision which is astigmatically neutral. So I think temporal approach is a very good approach for small incision cataract surgery. Either even we can form a small tunnel, or we can give incision which is approximately 1.5 mm to 2 mm away from the limbus.
So good afternoon, everybody. I would welcome you all for this session, which is, I believe, is quite important. I'm selective phacosurgeon, but for my CAM patients, for my small incision patient, the patient has come for small incision, would be done small incision. Similarly, at my institution, we prefer small incision because the people after doing their MS, they must be proficient with the small incision. At least then they can shift on to phaco. It's easy to learn and easy to propagate. So my choice when I have to do a small incision is always a temporal. So when you compare this temporal incision to a superior tunnel, it's in the case of a deep set eyes, small orbits, it's very difficult to approach the eyeball. It's really cumbersome. When you have a chemosis, again a cumbersome. When you relate to the complication related to the tissue we are handling, starting from the conjunctiva, many times we have a conjunctival laceration, a buttonholing, stuck in wound, afterwards granulation formation, retraction or bleeding, direct, indirect ciliary body insult. In sclera, we have creation for the temporal scleral tunnel is difficult. Again, buttonholing. Maybe you have an early entry, thicker scleral flap, superficial, or a thinner flap, cortex-induced inflammation into the tunnel, maybe a bleeding from the perforating vessels, and direct injury if it's a deeper to the ciliary body. Even otherwise, we are working directly over the ciliary body. It's going to induce inflammation. Similarly, the long tunnel, when you approach sclera, it's a difficult maneuverability because of the less space as you see in these photographs. When you reach the temporal incision, that's why possibly because it was temporal, Dr. Karamjit could do it from 2.2. We have enough space and maneuverability. I would share a few of my SICS patients, surgeries. So one is a mature, the other is not very mature cataract. So you prefer a limbal, prelimbal or corneal. I would always prefer prelimbal. It's going to give me a veil of conjunctiva to cover the incision line. So these are my usual steps in all of my patients. 2.2 or 2.8 entry, visco, extension of the 2.8, rhexis, nucleus delivery after hydration, with the irrigating vectors, followed by irrigation aspiration, no side port, preferably no trypan blue ever. If the nucleus is hard, your vector is going to help you. You can fracture it in the tunnel, pull it into the tunnel, you can fracture it automatically into two halves, or you take a segment. We have a C-shaped nucleus left which we can just clock around, push it out. So few of our patients, I have seen around 5 to 10% patient has exfoliation, compromised zonules, hypermature cataract. So they are difficult to be maneuvered with the superiorly placed tunnel, but temporal is easy to weigh. This is a hypermature Morgaginian cataract wherein I have initiated the rhexis with the keratome itself for the beginners. So once you have done the entry through the rhexis, then you can have an easy access with the forceps or with the scissor. So it's not the saving time, but ease of steps, which my choice is for the small incision cataract surgery. So once you have done with the rhexis, you can prolapse the nucleus with a viscoat, if not with the hydration. Have enough space behind the nucleus between the capsule and this, and then you can turn the way I'm doing it, and you can pull it out without much stress to the cornea and the bone. So we are exposed to Dr. Daljit Singh's irrigation aspiration cannula, which is a two-way cannula. This is a Simcoe. So I usually prefer that. Few of my video you would see one coaxial, the other are Simcoe or reverse Simcoe. So this is a real-time small incision, the video, the first on your right. So usually my time is around 4 minutes when I have to have a camp surgery done. It's not the time which I have to see it's a safely gone through. So this ease of steps which we have incorporated so that there's not wastage unnecessarily. So once you have a conjunctival flap made, you have to cauterize, then you again reach to the sclera, a long tunnel you have to create. So that to me it appears cumbersome. So temporal, since then I've started from say 15 years back. This is a half circle moon which we can just let it prolapse with a visco or with the fluid, even in harder of the hardest cataract. So once you have a good hydration of the nucleus, the expression would take out the much of the cortex. If you have less of the cortex, the aspiration is easy. So we would build a confidence. Any complication if we come across in a small incision is the aspiration. You mingle with the iris, you mingle with the PC, you mingle with the capsule. So people is going to be constricted and it's going to add to our complications. So have a good hydration, let that come out, and then you proceed. These are the 1 day post-op. I always use the bubble there. So we have compared the astigmatism in SICS and superior, and in all my around 150 patients in each we took the induced astigmatism was 1 and 1.5 in superior. And so the visual acuity is much better in small incision. Early recovery, even our follow-up is 1st, 5th, 15th, 40th day. We have taken till 6th day. The vision in all steps was better with temporal incision as compared to superior incision. Thank you.
Thank you, Dr. Shakeen, for showing us your wonderful surgeries. It's always a treat to watch you your videos and watch you operate. Thank you once again.
Thank you, sir.
And now I would invite Dr. Gurvinder Kaur. She will be speaking on crafting the perfect incision, the key to success in small incision cataract surgery. शाम ਨੂੰ ਆ ਰਹੇ ਹੋ ਨਾ?
So good afternoon. So at the beginning, I would like to, because I'm seeing so many young faces here, so I like to highlight two things. One, there is no competition between phaco and SICS. And two, there is no harm in learning two different techniques of doing the same surgery, so that we can use it to the advantage of the patient according to the nature of the cataract. So my talk today is crafting the perfect incision in small incision cataract surgery. So in SICS, the incision is not just a surgical entry wound. It is a valve, it is a refractive element, and it is also the determinant of safety. So the incision actually serves multiple purposes. It gives you a surgical access, it ensures wound stability, it controls your post-operative astigmatism, and it minimizes the risk of complications. So our goal here is achieving a large self-sealing astigmatically neutral incision that balances the surgical needs with the optimal patient outcome. So there are various kinds of incision shapes in SICS, and accordingly there are various kinds of induced surgical astigmatism. So coming on to the shape, you can have a straight incision, smile incision, frown incision, chevron or a inverted V incision, and a inverted boat-shaped incision. So these are actually, as the name suggests, they are self-explanatory. There is something known as astigmatically neutral funnel. So if you can look at the funnel, the width of the funnel is narrower as you go closer to the limbus, and it broadens as you go away from the limbus. So all your incisions should be placed between this funnel. So as you can look at the shapes, the chevron or the inverted V and the inverted boat-shaped sutures, incisions, they are actually in this funnel. If you remain in this funnel, it will be astigmatically neutral. Also, as we already saw in the previous two talks, you can have your incisions placed at various places according to the astigmatism. So you can have a superior incision. So those are actually the traditionally you do SICS from the superior incisions, but nowadays you can do it through temporal incisions also. So the temporal incision is the one which induces the minimal surgical astigmatism. So this is just a table showing you the induction of surgically induced astigmatism. As you can see, the inverted V suture and the temporally placed suture, they induce minimal astigmatism. Also, in addition to the incision, the external incision, the type of tunnel which you make also decides your post-operative astigmatism. So the shape of your tunnel should be a trapezoid shape. What does a trapezoid mean? That you should have a smaller external incision at the sclera, a larger internal incision at the cornea, and your tunnel length should be appropriate. So we'll come to this one by one. So the geometrically neutral tunnel is if you have an external opening in the sclera of about 5.5 to 6 millimeters. We are talking of the usual SICS, not the SICS which is done by experts in the 2 mm or other techniques. So the internal incision should be about 6.5 to 8 mm. This is in the cornea. The tunnel length should be about 3 to 4 millimeters. And the depth at which you should make the tunnel should be at 50% of the scleral thickness. So when you construct the corneoscleral tunnel, so the external scleral groove is usually made by the crescent blade. So that crescent blade, the external incision again should be 5 to 6 millimeters in width. The depth should be 50% of the scleral thickness. You can decide what incision shape you want to make. The frown is easy to make. Even the inverted boat-shaped incisions are easy to make. And it should be about 1.5 to 2 millimeter behind the limbus. If you go too far away from the limbus, maybe the neutrality will be there of astigmatism, but the manipulations during surgery become difficult. Then the tunnel formation. So from the external wound, you start going towards the cornea. with the crescent blade, and you maintain the lamellar plane at about 50 to 60% of the scleral thickness. The length of the tunnel from the sclera to the internal corneal incision should be about 3 to 4 millimeters, not very large. A small incision will not give a valvular effect and a self-sealing incision tunnel, and a large tunnel will make all the maneuvers very, very difficult. So your internal entry should be like you do in phaco. So your internal entry should be with the 2.8 keratome, and you should extend that. It should be in a triplanar manner, and you should extend that to make the internal incision about 6 to 8 millimeters, according to the external incision which you made. So the triplanar design will help in self-sealing of the wound. You will go sutureless. But whenever you are in doubt, if there is wound lake, please do not hesitate to put sutures. So you, in case of this is the external incision, internal incision, and the tunnel. The another aspect is making these side pockets. They are very, very important to facilitate the delivery of a very large nucleus. So in the end, I will just summarize. There are 6 surgical rules. One, that the external incision shape should be either frown or a inverted V or chevron. 2, you can decide to place them temporally. 3, the tunnel should be of the shape of a trapezoid with a smaller external incision and a larger internal incision. The tunnel length should be optimal, about 3 to 4 millimeters, and it should be in a triplanar manner so that it is self-sealing. And the 6th safety rule is, whenever you are in doubt, please place sutures. One suture is better than risking the patient with endophthalmitis or hypertony. So if you master these 6 rules, you master SICS incisions. Remember, again, incision is not merely an entry point. It itself is a sophisticated surgical tool which finally determines the success of the entire surgery. Thank you.
Thank you, Dr. Gurvinder. And I would like to add a 7th point here. The wound in SICS is always covered with a conjunctival flap. All other wounds are exposed to the vagaries of the environment, which is a gift to the patient from an SICS surgeon, I would say. Thank you. And now I would request Dr. Manisha Nagpal. She'll be speaking on the art of hydro procedures in crafting successful nuclear prolapse in manual SICS. And interestingly, I would like to add something here. Manisha was to go in for a very major surgery, and she had to give the consent for this instruction course. And she was telling her husband, give this consent on my behalf. I may come out of the theater, I may not come out. Thank you, Manisha. Best of luck. Have a wonderful life ahead.
Thank you, God, for coming out from open heart surgery. Today I am standing in front of you. I gave the consent on that day of my surgery. Today we will be discussing on the art of hydro procedures in crafting successful nuclear prolapse in manual SICS. Nuclear prolapse is the most challenging step. Proper technique implementation makes prolapsing easier. Ensure you have a properly sized CCC, minimal 5.5 to 6 mm, because small rexes can cause capsular block after hydro procedures. Before we understand the principles of the hydro procedures, we should know the surgical layers of the lens. It can be divided into capsular bag, superficial cortex, epinucleus, and endonucleus. Hydro procedures, it helps in freeing the nucleus from the capsule and great help in prolapsing the nucleus out of the bag. It lessens the jonular stress. It can be divided into hydrodissection, means to cut or to separate, hydrodelineation, to demarcate between the 2 points. This is a historical context. It was coined by Faust in 1984. Fine described the cortical cleaving hydrodissection in 1992. So it is the injection of fluid to separate the lens nucleus from the cortex to facilitate the mobilization and easy and safe removal of the nucleus. Here the fluid wave goes through between the capsule and the cortex. This is the dissection. Caution: whenever you are starting hydrodissection, always wash visco in AC before. because we should partially empty the AC, so for fluid to come out and should not land up in PC tears, because it should not be done in pressurized anterior chamber. Always use a main incision, never use side port for hydrodissection. So we use here the 2cc or 3cc syringe and 27 gauge or 26 gauge cannula for the instrumentation. Here we discuss the following steps in further. Where to place the fluid. I also have been teaching youngsters like beginner giving trainings. They always try to push the fluid near the rhexis margin. They hesitate to go near the equator of the lens. So I have been training, they always find difficulty in hydrodissection. They'll end up in doing hydrodelineation only, and then the cortical cleanup become very difficult for them. So it is very important where to inject the fluid, near the equator of the lens. Now, how to start? Most of the beginners, they don't tent up the anterior capsule. So we have to tent up the anterior capsule margin away from the cortex and go near the equator of the lens. Then the slow injection begins, slow wave, and then the rapid pulse injection. This results in a temporary intraoperative capsular block, which have to be released in the next step. It is characterized by the enlargement of capsular axis diameter. So here we have to press the lens posteriorly from the opposite side to relieve the cortical capsular connections in the capsular fornix and under the capsular flap. So it can be repeated in the opposite distal quadrant followed by delineation. Adequate hydrodissection can be demonstrated by ease with which the nuclear cortical complex can be rotated. So rotation, it is the telltale sign we will discuss. Safe position. You have to use a 2cc syringe, left hand holding the cannula hub. There should be no air in the syringe, plunger resting on the MCP joint. Avoid air in syringe. Avoid unsupported cannula. Avoid plunger resting on phalanx. How much force? They don't know how much force is required. So we should know like how much force I will show in the video. Like it should be proportional to the rate of flow and cannula resistance, either 30 or 27 gauge. It is sufficient resistance to generate the necessary force. 2 ml syringe is small enough to provide good tactile feedback regarding the rate of flow. Like this, key should be the slow and steady force. The force should be few inches away from the tip. It should not be like that going straight as in seen in video. This force is more. So we should assess the force, how much force should be there. Fluid, just 0.5 to 1 ml of fluid. We don't have to push more fluid. Rotation, you can like in the beginning, we can see that our hydrodissection is sufficient or not. We can see the rotation of the nucleus. I always tell the beginners that if you are not confident that you have done the hydrodissection, you just check the rotation as you see in the like phaco, so that you can prolapse it later in the AC. Like we prefer to prolapse one fall of the nucleus out of the bag with hydrodissection. For softer cataracts, we can do visco-dissection as well. If we are like not sure of putting more fluid, we can use visco because it prevents the AC collapse and cushions the PC during nuclear prolapse. I would like to give courtesy to Dr. Kuwar Dhaliwal for this video. So, can you put this mic off? You just have to go beneath, like you can see the fluid wave. You have to pass. Now prolapsing hydroprolapse. We can now see in the posterior polar cataract like hydrodissection, how is to be done. You have to partially empty the AC. Then tenting up of the margin. This is the fluid wave. Thank you. Signs visible during hydrodissection. You have seen the advancement of fluid wave. Wave should not be very fast going to the other side. Sometimes you see the wave, but it is going very fast. It means it is going through the lens. This is causing hydration of the lens. Then anterior movement of the nucleus, stretching of CCC, shelling of AC. There's a hydrodelineation I will be discussing as well. You have to use paracentral zone. Cannula is embedded into the substance of the nucleus with the classical sign of golden ring sign. This step allows to have a smaller endonucleus, so it is useful in softer cataracts. And you can see the classical golden ring sign here. This is the do not force hydroprolapse of the nucleus in hard cataracts and smaller axes. Avoid hydrodissection in posterior polar cataracts. These are some complications which can be done at the time of hydro procedure, because sometimes beginners don't know when they have done the PCR. They want to know when we have done the PCR. So these are the complications we see during hydro procedures: pupil snap signs, sudden deepening of the AC, inability to rotate, and iris prolapse. The most common mistakes: inappropriate placement of the cannula. So most of the time they put inside the like below the iris, they go into the granules, which can cause the fluid misdirection syndrome. So we have to know, we have to tent up the margin, go inside near the equator of the lens. Incomplete fluid wave, not using enough force, wrong technique of decompression, amount of fluid may be less or excess. So take home message, these are the signs we can see, and thank you.
Thank you, Manisha, for that wonderful talk on hydro procedures. Now I would request Dr. Mita Joshi. She'll be speaking on difficulties in nucleus management and mastering nucleus delivery.
Good evening, everyone. At the outset, I'd like to thank AIOS and Dr. Dhaliwal sir for this opportunity. We have seen how to begin, but well begun is half done, and you have to complete the process. The nucleus has to come out, right? So, as we all know, cataract surgery is one of the commonest surgeries in the world, and the advances which are there have been ranging from couching to femto. MSICS has a unique place in this armamentarium because you can do high volume surgeries at low cost. Complicated cases can be handled with ease. There is a less steeper learning curve. Astigmatism control can be done with the incision placements, and you can put premium lenses also. Surgical steps, you can either go for peribulbar or topical, conjunctival flap or transconjunctival. Scleral dissection can either be superior temporal or on steep axis. Rhexis, we usually prefer a circular rhexis around 5.5 to 6 millimeters. Hydro procedures have already been discussed. We'll be seeing about the nucleus delivery, and then rest of it is the cortex removal, IOL insertion and closure. Delivery of the nucleus will be in two parts: from the capsular bag into the anterior chamber, and then from the anterior chamber to out of the eye. So you can either use a single instrument by hydroprolapse or tire wheeling, or use two instruments like the iris spatula and a dialer or a Sinskey hook. So this you can see the second image where the two instruments, a spatula, thin spatula and a Sinskey hook are being used. The nucleus can be delivered out of the AC by any one of the techniques. You can either use an irrigating vectis, a phaco sandwich procedure, phaco fracture technique, modified Blumenthal technique, fish hook or visco expressions. Now, nucleus delivery, what problems are usually faced by beginners? So you can either have an iridodialysis or a zonular dialysis because the nucleus just keeps on rotating in the bag and doesn't come out of the bag. Corneal edema, because bringing the nucleus from the AC into outside, you will be rubbing against the endothelium a lot of times. Once you have more than 3 or 4 efforts, you are definitely going to land up with corneal edema. And in all these manipulations, you end up with a small pupil. So even if your nucleus is out, you don't know how much cortex you are leaving behind, right? And zonular dialysis also is one of the feature that once you are keeping on rotating it, you don't know when you have damaged the zonule, and suddenly you find that from one corner vitreous is peeping out. So my tips for dealing with this problem would be: 1, your tunnel size should match your nucleus grading. If you have a grade 4, grade 5 nucleus and you say you will be doing a 4.5 millimeter incision size, for a beginner it is a no-no. Have a large incision, put a suture, right? Then adequate viscoelastic use it. Koi baat nahi, 2 syringe lage chalega, but the cornea should not suffer, the endothelium should not suffer. And appropriate, one more point would be the size of the rexus. A 5 millimeter rexus, you are not confident, you are not able to increase it, put 3 nicks, no issues. But you should not have a zonulodialysis, right? So your nucleus should come out of the bag easily, and appropriate technique for appropriate nucleus. So this is from a bit from the beginning. Entry into the anterior chamber, hydrodissection. You can see the golden ring. And then you check the mobility of the nucleus. Put in a Sinski, gradually pull, push it to the center and bring out one edge of the nucleus, and then just rotate it gently without putting any stress on the zonules and bring it out into the anterior chamber. Once you are sure the whole nucleus is in anterior chamber, put a visco cushion between the endothelium and the bag also, so that your endothelium is protected and the posterior capsule is also protected. And since this is a smaller nucleus, you can just gently increase the visco pressure and put pressure on the tunnel, posterior part of the tunnel, and bring the nucleus out. This one is with the vectus. So be sure you are able to see the inferior edge of the vectus at all times. It should not catch the iris, and then gently pull it out. Right, again same thing, hydrodissection, removing the nucleus from the bag into the anterior chamber, gentle rolling of the nucleus, bring one pole out and then rotate to bring it into the anterior chamber. Put adequate viscoelastic. Press on the posterior lip, injecting viscoelastic all the time below the nucleus. And voila, your lens is out. Right. Then if you have a harder nucleus, what do? You can do phacosection. Just run through the videos. This is a small pupil and we are not able to bring the nucleus out. So what you can do is, this is one, so you are sure that you have handled a lot of cases, you can just flip the nucleus. I think Sir Dhaliwal sir also has described this technique. So you can just flip the nucleus, but you have to keep on injecting visco all the time. Remove all the epinucleus material first, so that you know how the size of the main nucleus, the core. Give a gentle push and that's it. You have flipped the nucleus, and then you can now bring it out into the anterior chamber. ensure complete rotation, ensure visco both above and below the nucleus, and then put in your second instrument. Here we are using vectors. A long, slimmer vectors can help you with plan a smaller incision once you are perfect with your larger incisions. Put in the dialer. Be careful not to rub the endothelium, and just divide the nucleus into two and bring one piece out. You can use a visco cannula also, as described earlier, and the second piece can then be rotated and aligned vertically, the long axis with the entry of with the tunnel, and then you can remove it either with the cannula or with viscoelastic if it is soft enough. And this is what you should not be doing. Iris and everything is out, then you have to push it in gently and put a suture, right? Irrigating vectors also can be done by hydro expression, also can be done, but then this needs an AC maintainer. Thank you very much.
Thank you, Dr. Meeta. So, audience, any question from the audience? We are through. Yeah, we have 3 to 5 minutes. So, any question from you? Any question from the youngsters? Okay, so if there are no questions, so we have come to this very interesting instruction course on SICS, and as sir has said that SICS is a technique for all seasons and all reasons. So I think everybody agrees that you may not be able to do phacoemulsification, or as I put it, a good phacoemulsification in all the cases, but yes, you can do a good SICS in all the cases. Whatever there are, any type of cataract, any grade of cataract, any complication, small pupil, PEX, zonular dialysis, a rent, posterior polar cataract. So SICS is a very good technique to learn along with phacoemulsification. Is there anything more?
Thank you everybody for having made it to this instruction course, and I would utilize this occasion to invite you all over for another instruction course on Sunday morning, where David would be putting up with the Goliath. There's an instruction course on flax, phaco, and manual SICS and a hard black nucleus. So please make it there too. Thank you very much.